Hi everybody, my name is Kaylee Brown and this is my oral abstract for The purpose of this study is to explore the implications of oral or topical administration of probiotics to existing cases of acne vulgaris. According to the American Academy of Dermatology, acne vulgaris is the most common skin condition in the United States. It affects up to 50 million Americans every year. It usually begins in puberty and affects many adolescents and young adults. About 85% of people between the age of 12 and 24 will experience at least minor acne. According to Lin et al. 2016, acne vulgaris can occur at any stage of life and continue on into one's 30s or 40s. Acne vulgaris can occur in adults, and the prevalence of adult acne is increasing, affecting up to 15% of women annually. Acne vulgaris consistently represents the top 3 most prevalent skin conditions in the general population, as found in large studies from the UK, France, and America. The rising incidence of acne vulgaris in late adolescence is a global issue. However, the cause is unknown, whether it's from an increase in the prevalence of a Western diet, earlier onset of puberty, a genetic drift, or a byproduct of unknown environmental factors. To begin, Lin et al. 2016 describes acne vulgaris as a disease affecting the pilosebaceous unit, or PSU, of the skin and is typically described as either non-inflammatory, which would be open and closed comedones, or inflammatory, which are papules and pustules. This picture depicts the following explanation that I'm about to explain. I know the words are small, but those words are in the picture are not what I'm going to be talking about, so the animation is all that I need you to be able to see. So the bottom of the PSU is lined with basal stem cells and provides structural support for hair follicles, erector pili muscles, and sebaceous glands. However, the basal stem cells can turn into sebaceous cells and keratinocytes that produce oil and hair by the stimulation of hormones such as androgen. The central canal of the PSU is lined with squamous epithelial cells, also known as ductal lining cells. Hormones, again, such as androgen, can also stimulate this layer of PSU and activate the sebaceous cells, keratinocytes, and ductal lining cells to begin proliferation. Once the excess ductal lining cells can't escape the PSU, they form a plug that causes sebum production and hair growth to continue only underneath the plug. This creates pressure that decreases the availability of diffusible oxygen to the cells below, which constrains their metabolism and provides an ideal environment for Propionibacterium acnes, or P. acnes, to grow. An overproduction of sebum occurs and serves as food in the form of fatty acids to feed the bacteria that is rapidly multiplying within the PSU. Once the growth beneath the plugged PSU surpasses the amount that it can hold at this point, the bottom of the membrane bursts and the contents are exposed to the body's immune system. White blood cells recognize the lipoproteins of the contents from the plugged PSU, and toll-like receptors 2 and 4 stimulate keratinocytes to secrete interleukin 6 and 8, which give rise to erythematous inflammation. Eventually, inflammation mediators recruit the white blood cells to attack the pathogens, which results in forming extra erythematous pustules. Over time, the inflammatory response repairs the damage in the PSU and the skin returns back to normal. Bo, Patel, and Logan, 2013, explained that acne vulgaris has long been featured as a gastrointestinal mechanism that dates back to 80 years ago from dermatologists John H. Stokes and Donald M. Pillsbury. Stokes and Pillsbury hypothesized that emotional states such as depression or anxiety could evoke dysbiosis, increase intestinal permeability, and contribute to systemic inflammation. Stokes and Pillsbury were among the first to propose using the probiotic strain Lactobacillus acidophilus. The gut-brain skin theory has been studied deeply in the last 8 years and has further been validated from modern scientific studies. It is evident that gut microbes and oral probiotics could be linked to the skin, and particularly severe acne, by their ability to influence systemic inflammation, oxidative stress, glycemic control, tissue lipid content, and even mood. The relationship between gut microbiota and skin may also be influenced by one's diet. Note et al. 2017 explained that probiotics are live microorganisms that can exhibit health benefits when consumed in adequate doses. The most commonly used microorganisms are Lactobacillus, Bifidobacterium, Enterococcus, Propionibacterium, and some yeasts such as Saccharomyces boulardii. Their health benefits include the prevention of antibiotic-associated diarrhea, treatment of irritable bowel syndrome, and inflammatory bowel disease. Sikorska and Smoragiewicz, 2013, explained that probiotics prevent the colonization of pathogens in the gastrointestinal tract through 3 mechanisms. First, probiotics compete with pathogens for binding sites and/or nutrient and growth factors. Secondly, probiotics produce organic acids, which lower the intestinal pH and inhibits pathogenic growth, and also increases peristalsis, which indirectly removes pathogens. Lastly, probiotics modulate the host's immune system by producing substances like bacteriocins and other metabolites that are toxic to pathogens. Jung et al. 2013 conducted a prospective randomized open-label trial. 45 female patients aged 18 to 35 years old with mild to moderate acne vulgaris were enrolled into 3 groups which are shown below. Total lesion counts, inflamed lesion counts, and non-inflamed lesion counts were assessed over 12 weeks. By week 8 and by week 12, the group receiving both probiotics and minocycline had significantly lower total lesion count compared with those taking only probiotics or only minocycline. All 3 groups had a significant improvement in non-inflamed lesion count at weeks 4, 8, and 12. The probiotic-only group experienced a greater decrease in non-inflamed lesions than the minocycline-only group at weeks 4, 8, and 12. With regard to the inflamed lesion count, subjects who took either probiotics or minocycline achieved an improvement by week 8 and continued to improve significantly by week 12 compared with baseline. The group that received both probiotics and minocycline experienced a significant reduction as early as week 4 and continued to improve significantly more with the other groups by week 12. By week 12, groups A and C experienced a greater decrease in total inflamed and non-inflamed lesions when compared to group B. Fabrocchini et al. 2016 conducted a pilot randomized double-blinded placebo-controlled study. 20 adults aged 30 to 37 participated who all had acne vulgaris. 10 participants were randomly assigned to 2 groups. 2 paired skin biopsies were performed on each participant, once pre-treatment at baseline and once at the end of the 12 weeks. The biopsies were analyzed for factors that stimulate insulin and gene expression. Those factors were insulin-like growth factor 1 and forkhead box protein O1. Clinical efficacy was tested by the investigators' global improvement rating on a 5-point scale. The probiotic group demonstrated a 32% decrease in insulin-like growth factor 1 and a 65% increase in forkhead box protein O1 from baseline. The placebo group did not exhibit any differences. The probiotic group was more likely to be rated as improved or markedly improved versus worsened or unchanged when compared to the placebo group. Fabbricini et al. Concluded that the probiotic supplementation may normalize skin expression of genes involved in insulin signaling and improves the appearance of adult acne. The last two studies I've discussed involved a dietary probiotic supplement. This study tested the efficiency of administering a probiotic strain into a topical cream. E. facialis SL5 was the probiotic strain used, and it was developed into the topical cream called CBT-SL5. 70 participants that were at least 12 years old and clinically diagnosed with facial acne vulgaris participated in the study. The participants were randomly assigned into the groups shown below. Participants cleansed their faces and then administered a thin layer of their respective lotions twice a day, once in the morning and once in the night. Each participant was examined at baseline, week 2, 4, and 8. 2 dermatologists each counted the amount of non-inflamed and inflamed acne lesions on each participant at each visit. Facial oiliness, peeling, and dryness were also documented throughout the study. The CBT-SL5 group experienced a decrease in the non-inflamed lesion and the inflamed lesion count, while the placebo group only experienced very small changes in both counts. The findings indicate that CBT-SL5 topical treatment may enhance the appearance of acne by killing the P. acnes and in turn reducing the production of inflammatory mediators that are synthesized and released from the pathogen. CBT-SL5 may also directly suppress inflammation on the skin. The results indicate that anti-P. acnes activity of E. facialis SL5 has potential role to the treatment of acne as an alternative to topical antibiotics. All of the studies that I shared in this presentation implied positive results toward using probiotics to enhance acne vulgaris. I chose the 3 studies that I shared because they all used human participants. 2 of them also used dietary supplementation. Human participants and dietary supplementation were the gold standard in my search criteria because they are most generalizable to the nutrition field, as human studies are better than animal studies or in vitro studies, and the supplementation as opposed to topical treatment applies more to us as dietetic students. These are all my references. Thank you for listening to my oral abstract. I look forward to listening to all of your oral abstracts and to hearing your oral presentations. I also look forward to presenting my oral presentation on the 3rd weekend of our class.